session in the chat. So please do use that and write any questions that you have, and we will draw out some to talk about amongst all the other panelists as well. And it now gives me great pleasure to hand over to Dr. Rani Thakkar from the Royal College of Obstetricians and Gynaecologists. Rani is the president of the International Urogynecological Association and has previously served in the British Society of Urogynecology as well. And we're absolutely thrilled to have you here. Dr. Rani, over to you. Thank you so much.
Thank you. And thank you, for Kitty, for your organization. Thank you on behalf of the college as well. Good morning, good afternoon, good evening, wherever in the world you are. Thank you for spending your weekend with us. Thank you also to Lifebox for hosting this event with our college, and to our panelists who are going to share their knowledge and experience with us. I guarantee you this is going to be an experience you won't forget. So I'm going to start off by introducing our panel. If you could change the slide, Kitty, thank you. First panelist is Professor Shaheen Rahman Chowdhury. She's an RCOG fellow, professor and head of the department, and she works in Bangladesh. He's also the chair of our International Representative Committee in Bangladesh. Our next speaker is Professor Tim Draycott. He's my fellow vice president while I look after global affairs. He deals with clinical quality. He's a consultant obstetrician in Bristol, and I'm sure all of you have heard of PROMPT, which is his training course, which he runs worldwide. Dr. Leonard Kavango is the Chief Medical Officer of the Namibian Ministry of Health and Social Services. As a general practitioner, he works in Kobabis Hospital, where he implemented the Better Birth Checklist and is a Lifebox faculty. Dr. Adolfo Leao is an obstetrician, and he works in Brazil. I cannot think of a better place for us person to have from a better place than Brazil, where they have the highest COVID rate and the highest cesarean section rate. So we really are looking forward to hearing your experience. He's also a fellow at the Harris Birthright Center, King's College Hospital, London. Dr. Nuru Muhammad is an obstetrician and gynecologist working in Ethiopia, and he is a member of Ethiopian Society of Obstetricians and Gynecologists. That's rather a mouthful. Dr. Meena Samant is a senior consultant, and she works in Bihar in India. She's the chairperson of FOXI Research Committee and Secretary General of ISOPAB. We also have with us Dr. Milind Shah, and he's an obstetrician who works in Maharashtra, India. Dr. Shah is a Deputy Secretary General of Asia-Oceania Federation of all Perinatal Societies. He's the past president of ISOPAB and also the past vice president of FOXI. He's also a Lifebox faculty member. Welcome to you all and to all attendees of today's event. It doesn't somehow seem right to start without acknowledging the hardships caused by the novel coronavirus in these unprecedented times. I think it would be fair to say that overnight our worlds were turned upside down. And most of us have experienced the effects ourselves through family, friends, or colleagues. Our personal and work lives have changed dramatically, and we are now grappling to find out what the new norm is going to be. We have all witnessed the terrifying devastation that this pandemic has brought globally, both in number of lives that are lost, and it's also pushing health systems to the brink of collapse. Globally, WHO has reported over 28.5 million COVID-19 cases and almost 1 million deaths. And as healthcare professionals, we are all aware that this pandemic is far from over. Our elective work has virtually come to a standstill, but obstetric work continues. Now we know that a large number, almost 18.5 million C-sections are performed every year worldwide. And this doesn't even take into consideration the other obstetric procedures. Thousands of healthcare providers have been, are, and will be performing C-sections on COVID positive or suspected COVID patients. Our workload has continued. Whatever has happened in the rest of the world, we have continued delivering babies. And yet, we have had to work with key resources being diverted, infected patients, lack of protocols, mixed protocols, confusing guidance, and lack of PPE. And all of this while we're trying to do our day-to-day job, keeping mothers, babies, ourselves, and our colleagues safe. We hope that today will help you provide some clarity to what has been a really confusing picture as we learn from the lessons that others have learned and draw upon our experience, which spans over the globe. A quick reminder for those of you wishing to watch this webinar in either French or Spanish, I'm really pleased we are able to be multilingual. Head to the bottom of your screen, select the globe icon, and write any questions you may have so that we can answer them. Now, before we start our discussion, I wanted to have an icebreaker. And what we are going to do is have a look at this picture. And this is what we call a CAT scale, which shows different types of emotions. And I want you all to think, first the panelists, as well as all our attendees, what was your feeling when the pandemic hit us? How did you feel? Choose your number. And as the attendees are choosing theirs, I like my panelists to tell me how they felt. So I'm going to start with Milind. Milind, how did you feel? Can you unmute yourself? All of you need to unmute yourself.
It was basically the number one for me because when it started, there was a lot of confusion. And
so you felt lost.
Yeah.
You felt lost at that time. Tim?
It took another, the 15 days by which we understood.
Just one word, Milind. Just tell me a number.
Yeah.
Number
I said
one, you felt lost.
I don't know. Of those, I think probably overwhelmed.
You felt overwhelmed. So you were overwhelmed is number 6.
Mm-hmm.
Yeah.
Leonard? Dr.
I felt overwhelmed as well.
You felt overwhelmed as well. So you can see different emotions. Shaheen?
Terrified.
You felt terrified. So you felt number 3. Adolfo?
Same for me. I felt overwhelmed from the news.
And Meena?
I think I would also, though I've gone through all the kind of emotions, this overwhelmed is something I would say.
Overwhelmed. And now let's see, has Nuru arrived? If he hasn't, then we'll move on to see what our audience felt.
Mm.
Oh, let's see, most of them felt terrified. You can see there's mixed emotions.
Yes.
The highest was being terrified, overwhelmed. Well, you can see there were 2 who felt quite smug. Oh dear. And there were 4 who felt quite relaxed. But majority fit in with being terrified, shocked, overwhelmed. That's how we all felt, really, isn't it? Thank you so much for your participation with that one. That was just an icebreaker, but what it highlights is that we were not ready for this. We were not expecting this, and it really caused a whole lot of mixed emotion. So now I'm going to ask each one of you a question, but before we go to that, I want each one of you in 2 minutes to tell me what the key challenges was to obstetric care that was caused by COVID-19 to your facility, and what changes you made in practice to address this. So you have 2 minutes each because we have lots of questions. So shall we start off with Milind?
Yes. Thank you very much, Rani. In fact, when this pandemic started, the biggest challenge was setup, because all those cases were referred by the local administration to the government sector. But many women, they wanted to come to the private sector as well, whereby the authorities were not allowing us to manage those cases in the private sector. With little more churning, discussion, then slowly the private sector also came into the practice, and we could overcome that challenge. And now the people have choice either to go for government as well as the private sector.
Okay. Shaheen?
Yes, that was obviously a shock for us when we recognized that in March 7th, we have the first case in Bangladesh. So we started with a mixed sort of response, because by that time, when the health professionals faced the challenge, we had to come with a mixed feeling, because a lot of community spread was there. And as I said, the structure was from the government has some sort of protocols to follow. And same like Milan, we have problem with the private sectors. And the most important thing and most alarming, I will say, we had problem with when we start with the triage system. That is the most important and difficult time I think we faced, with the fact that when you are talking about the triage is like a system of taking history examination. History was hidden by the patient. They are not declaring their history of exposure. They are not declaring their address of the hotspot. They are not declaring their fellows coming from abroad. And examination of patient looking for the temperature was also a big problem. People are coming with having paracetamol so that entry can be not restricted. And most importantly, we have problem with the testing at the beginning, because we have problem with the availability. Even you do the testing, taking long time, and obviously there is a quality concern was there. So that was the problem, and that is the time I think most of the health professionals affected with that system. Thank you.
So you had problems with your healthcare professionals being affected, your patients not being quite so honest, taking paracetamol to keep their temperature down, etc. We have heard of these stories elsewhere. Tim Draycott.
Yeah, thank you, Annie. In the UK, our main issue really was the organisation of our service. And exactly what we should do with testing and how we try and reduce the risk to mothers and also staff. Secondly, the risk was also staff having to quarantine and be isolated. But some of the most difficult things we had to deal with were changes to visitors, which was very difficult for many families. And also a lot of changes to antenatal care, in particular remote antenatal care. How can we use these new technologies like we are today for antenatal visits? So many challenges that were simultaneous, really.
Dr. Kabango?
Yes, exactly. It has been challenging as well from the beginning. You know, cases started very slow, up to 16 cases in the country, and there was actually a break, kind of if more weeks without any case. So probably that was good to make sure that other hospitals around the country could actually start preparing. Eventually, isolation facilities were a big challenge, because you needed to set up an isolation facility very quickly. Within a month, you have to complete a building if you are building a new facility, or you need to look at your existing facility and make some redesigning the way you're going to treat the patient. For obstetric, the most challenging thing was the patient flow. I mean, we can't stop obstetric. Patients still have to give birth. Yes. We still have to do cesarean sections. So how really do you know which patient is a suspect, which patient is a contact, we needed to set up a patient redesign flow very quickly and start screening every obstetric patient that comes in. But I think also the other thing that we did was to empower the midwives and the medical doctors into new trainings like case management for COVID-19, because it was just something new. We needed to gather information from left and right to see if we could have actually some evidence to start empowering people, at least the basics people they're supposed to know. This is on infection control practices, on surveillance, on screening, triaging, and case management, critical care. I think those are the things that we started doing, and of course up to now.
Yeah, thank you. Dr. Adolfo, what was your experience in Brazil?
Well, because we sort of had the opportunity to see the experience that happened abroad first before the pandemic really hit the country. I think the first problem was to deal with the fear that the crisis, especially seeing what was happening in Europe, Italy, a little bit of what happened in China, raised a lot of fear amongst the population, and because everything was so new, we didn't have many answers. So that was one big difficulty we had at the beginning to deal with. Brazilian people have a profile that is more excited about everything. So that was one thing. The other thing I think very much was said, problems to separate literally two hospitals, one for COVID-free patients and the other one for COVID pregnant women. So the patient flow was also a big problem for us to have the setup to deal with these two patients separately. And the third one, I think, was the availability of testing, which is still a big issue for us. We are still very much behind in that aspect to know. So we had to implement universal care for everyone, yeah, especially in order to maintain the health of our staff. Because people were not being tested and we could not rely completely on history, as said before. So we had to make sure all our staff would remain available to carry on with the obstetric care, despite knowledge of the COVID status of the patients that were being seen. So I think I would summarize in these topics.
Thank you. And Dr. Meena?
Yeah, I think when it came to the city of Patna, it came all of a sudden, because till then nobody was taking it seriously. It was almost as if it's part of the world. And suddenly there was lockdown. So patients were not prepared. The antenatal routine care patients, they were not prepared. And it was very difficult to tell them that the routine OPDs as of now is sort of only taking the labor cases. And because it started with a lockdown. Even our staff was not really, geared up.
Yes.
They were not geared up. We have to really impress the idea of social distancing even amongst our own staff. So it all started having to train each one of us. So almost every day, every other day, all the guidelines that were pouring in, that was being given out to them. So ourselves getting tuned to the pandemic and training our staff, keeping everybody safe was one important challenge for us. And also it being a very populous country, a busy OPD, and suddenly stopping all the gynae elective OTs and taking up only the labor cases was even something for the patients, trying to tell them that is the safest thing to do as of now.
Sure.
So those were the things.
Dr. Shah? I was already finished with you, yes. So you all described different commonalities. I think there's lots of things that are common, and there are some quite specific to the places that you come from. And some of them are to do with, a lot of it is to do with not being prepared. A lot of it is to do with lack of testing, perhaps. PPE did not come up, but I think it's because we are also used to assuming that there was lack of PPE everywhere.
Yes, yes.
And also, I think changing our systems completely. And I think people did it in different ways, isn't it? Some people had different hospitals, whereas, for example, in the UK, we made good of our own hospitals and divided them into COVID and non-COVID. So there are lots of really interesting aspects, and I'm sure there's lots we are going to learn from each other today. So I'm going to start off by asking Dr. Milind the question. Thank you, Dr. Milind, for being here this afternoon. I would like you to now draw on the key factors for pre-op, intra-op, and post-op preparation and management for obstetric procedures during COVID.
Yes. Yeah, there was a lot of actually the changes which occurred in all these actually three elements of obstetric care, because when this pandemic started, there was a lot of change in the protocols by various organizations. Though the basic principles were same and applicable to all, we needed to modify ourselves according to our hospital practices and resources. As I told you, when we started this in the private sector, we realized we need to have a lot of thinking about this pre-op, intra-op, and the post-op care as well, taking into consideration plenty of things. It started with the isolation itself, because when the testing was not very routine in the pregnant women, the government came to our rescue and they said that all those pregnant women need to be tested 5 days before actually the date of delivery or when she goes in early labor to understand what need to be done further. Now, we emphasized to all our actually staff members that we need to take the universal precautions, because though we say that the effect of this COVID in pregnancy per se is not very different as compared to the previous viruses we had like SARS and MERS, we needed to see that we should take adequate care, especially those women who have the comorbidities, where the things may change actually a lot. And we had another actual problem of this lack of healthcare worker attending the clinics, because they had the fear in their mind because of the lockdown curfews. People were thinking that it is going to be a nightmare. But slowly we then started, doing a lot of counseling pre-op itself about the things, and they started giving more compliance per se. For that we took the help of newspaper media, television and radio, where we deliver a lot of talks to make them comfortable. Same way about the healthcare providers as well. We needed to tell them about these PPE kits, which were actually definitely had some scarcity to start with. But then we came out with certain new modification, and we told them that the staff who is working in the ward can have a little modification. Those who are working in the OPD can have little more simplicity. But those who are working in the operation theater, we needed to see that they have a level 3 PPE kit wearing to avoid the contraction of infection amongst them. The donning and doffing takes a lot of time. So we took that also into consideration. We informed the obstetricians that we need to take the decision little more apt so that we can prepare ourselves with the whatever limited staff we have. The testing, actually we seen that though we had decided to test each and every actually person, we also saw that every woman was thought of susceptible COVID, and we started taking all those precautions. Now, when it came to the actual theater entry, I realized the challenge starts from our house itself. And then certain gadgets came into the market, especially this one, which I'm going to show to you all. It helped me a lot. It's a door opening for the car, as well as the one knob for pushing the buttons of the door. So that all that, fear the healthcare providers had about touching those door handles, because that was the main point where they said that chance of contamination is there. We started working from that itself. We made certain changes in the airway management, because we realized whenever there is aerosol generating procedures which we are going to have in theater, we need to have a proper actually protection for our anesthesiologist friends as well. The transfer in the patient, of the patient from ward or the room to the theater also need to be addressed very, very carefully. And we try to see that it is made like a green corridor by avoiding, the rush in that particular corridor area. In our country, the population, as Meena also was telling, was the biggest challenge, and even the getting compliance from all those people who had differences in their quality of education as well as their understanding about the disease. Then we started slowly adopting the safety checklist, slightly modified. We started calling it the COVID-19 surgery safety checklist, which we modified for our own setup, where we added one runner outside, and that was the brother or a sister. In India, the male nurse is called as brother, and the female nurse is called as a nurse, but many other countries they call nurse itself. But that runner nurse was a great rescue. He or she used to look after whatever is actually lacking, and a lot of burden which is there in the staff which is in the operation theater used to get reduced a lot. Then we saw that all those people who are in the theater, we tried to minimize those people. We had only two assistant one and assistant two, who will help that cesarean section in that total given case, and one pediatrician to look after the baby. And the runner, actually nurse, was helping all of us whenever we needed something for that need to be adopted. Then in the OT requirements, we needed to modify certain things. In our country, the negative pressure OTs were not dedicated for the any particular surgeries. We made certain changes in that with our engineer friends. We tried to incorporate more and more disposable equipments, and we saw that there are more experienced providers in the theater rather than keeping the student nurse or the student attendants or anesthesiologist, and that made a major difference. We tried to see that the anesthesia could be as far as possible the regional anesthesia, so that we can avoid all those complications of transmission of disease which happen because of this aerosol generating process in the general anesthesia. And we try to modify that way as well. But there are certain scenarios where regional anesthesia is not possible. We try to create the filters between the patient and the anesthesiologist. We thought of the curved ETTs, the placing HEPA and the HME filters in between to make it more safe for the people. We always call this as, needed to be done with the little simulation training and the good debriefing after every case, because every case teaches you something new as well, and we need to do that way.
Yeah.
The patients.
I'm going to have to stop you because you've run over your 5 minutes.
Yes.
Have you missed anything extremely important?
No, the only last point which I wanted to add, and the remaining things which I wanted to tell, we can cover in the question answer eventually when the audience asks us. Yeah. But what I realized that one thing, some of the actually the healthcare providers were not treating the patients with respect and dignity because she is COVID positive. So we gave them emphasize on that particular point that we need to give our all sympathy to that particular patient, and we should have very good communication with all our staff members, and we need to give them whatever they need actually in that particular, sort of frightened situation.
Sure.
Thank you very much.
Yeah, so there was a lot of, do any of the panelists want to add anything to that which is different, or did you all have similar experiences? I want to come back to the negative pressure OT later on if we do have time. Now, next I'm going to ask Shaheen. Shaheen, can you tell us whether COVID-19 is an indication for elective C-section, and when should it be considered in pregnant patients with COVID-19?
Thank you, Rani, for asking the question. So far, there's no evidence of increasing benefit of cesarean section versus vaginal delivery in COVID patient. We should be actually following the obstetric indication where applied. So my answer should be no in this, the first point. And the second question, as you have asked, when we should consider cesarean section in pregnant patient with COVID positive. So if you talk about that thing, we have to just exclude those parts. We are talking about the obstetric indications. So left that one on the other side. Now we have to talk, is there any situation where we can consider this sort of COVID patient needed cesarean section? Say, first of all, I'd like to say that this can be controversial or flexibility should be there because everyone will not accept this fact. But giving you some scenario, for instance, a lady coming in the labor room having COVID positive with high temperature, and she is having high temperature, it's not subsiding as such the way we expect. As a reflection of the high temperature of the mother, there is a reflection of tachycardia with the fetus. And if this is persisting for a long time, it gives a lot of stress to the health providers, as well as patient is taking as a stress. So these are the situation, or this particular situation, one can think of moving on to CD in this sort of patient. And keeping in mind, as we have discussed already before, a lot of mobilization actually happened within the staff. So there are places where the neonatal service is not as effective it was before because mobilization happened. And also the seniors with comorbidity, doctors are not around at the time as a frontliner. So these are the things need to be issued in this fact, and that can be justified. Taking another scenario, like if the patient is coming in labor and she's having some respiratory distress, and if you're thinking that this distress, whether this patient can cope up along with the first stage, in the second stage, whether she is able to cope up with the second stage when she require wearing down. So in those cases, if it is very subjective and individually need to be decided. So if the caregiver thinks that this is not possible, then one can not justified, I will say, consider for going for CD in that particular case. And another thing is very important, if a pregnant lady near term got infected with the COVID and she is in a situation moving on from category to mild to moderate, and if you're thinking this patient may go into more complicated phase, especially with the comorbidity, one can think of elective CD in this particular patient. And because it's important the fact that we have to take the decision the right time, because we can avoid the general anesthesia, we can go for the regional, and also if this lady subsequently needed ICU support, it is much easier to do this intubation and support to the ICU without the baby in the uterus. And another concern is that we know there are a lot of studies, not a lot of studies, few concern is coming about the vertical transmission. And it's not enough literature and not enough evidence. But as you know, our patients are more sort of aware now with the net information. So there are patients can talk about these things, whether there's a chance of having vertical transmission to my baby. So those are the situation one can consider. But from our point of view, obstetrician point of view, I don't think so that should be the leading cause for deciding CD. And finally, actually, I like to it's not the answer of my question, but I'd like to throw this to the round table, because it has been noticed, especially in our country, that trend of CD actually has been increasing during this time. So I will left it to the round table to discuss. I'm sure it is a global influence there, so we'll discuss about it. And finally, I'd just like to throw a little statement, because I was looking through the net, and the one where this thing started, they have stated 2 points. One is like they said that in terms of this emergency, this is COVID crisis, indication for CD for women with COVID should apply flexibly. So that is one thing I think as a take-home message we can take, and we can adjust ourselves with our facility. Thank you.
Thank you, Shaheen. Any of our panelists would like to answer Shaheen's question? Tim, I know you were heavily involved in our guidance from the college. Do you want to add anything? There definitely has been an increase in rates of C-section.
So, yeah, so that's an interesting challenge, Professor Shaheen. certainly there is data from China showing that women are choosing more defensive options. I don't think we're seeing that in the UK. The cesarean rate and instrumental rate seems to have been pretty similar, to be honest. In fact, we're just about to assess, although some people have published evidence in some hospitals in the UK of deterioration outcomes, certainly.
Oh, Tim is frozen.
I think in some areas, but that has not been replicated across the UK generally. Now, at the moment, I think we need to make sure, just like you said, we manage women obstetrically. We don't change their we don't change their management just because of COVID. And so I think we would try and maintain good obstetric standards even in these challenging times.
Yeah.
Dr. Adolfo, anything to add to that?
We sort of had the same observation as Tim mentioned. We didn't really notice a big raise in elective cesarean sections here. I think despite all the fear towards what was unknown, still unknown, I think people opted for a conservative management as to follow what was standard of care. We didn't notice any increased number of elective sections here.
Okay, thank you. So my next question is to you, actually. How was access to C-sections maintained during the pandemic? And what steps can be taken to ensure access to emergency obstetric procedures during the pandemic?
Talking first about elective cesarean sections, we made a change in the patient flow. Instead of patients having to come to the hospital for, patients are being cared in primary units, and then they have their elective cesarean sections at our unit. So instead of patients having to come to be seen personally, we had the referring doctor send all the data of the patient, and we would only bring the patient in for the scheduled date of delivery. So that was a big change in terms of the elective patients. But this is a small percentage, of course, of the procedures. This would involve the breech presentations, the two or more cesarean scares. That for the majority of cesareans, which are emergency cesareans, I think the strategies was to really maintain the obstetrical units up and running. Although we had a few hospitals that were turned into COVID hospitals and stopped offering obstetrical care, this obstetrical care was always redirected to other near hospitals. However, this often raised a lot of doubts because when a pregnant woman is used to go to a certain hospital and the next day she turns up there and they say, we don't offer obstetric care anymore, she doesn't really know where to go to. So this created some confusion. But with some time, this information managed to be spread, and the units that remained offering obstetrical care, I think the main concern was to guarantee that we didn't go into shortage of staff, right? And so a few measures were taken, like although people were not planning to travel, many people had vacation scheduled, so all these vacations had to be canceled despite legal obligations. These were exceptional times and we were allowed to cancel all vacations. We didn't, although some doctors had difficulties dealing with multitasking. I mean, you have small children at home, you cannot go away for a 12-hour shifts. I think at that moment, everybody helped each other. So the doctors that really were not able to attend hospitals, their shifts were taken over by other colleagues that were available. We didn't really come to a great shortage of people, and people falling sick. Fortunately, we managed, because the pandemic struck us later on, a lot had been learned about the proper use of PPEs, the masks, face shields, cleaning procedures, and so that managed to keep us up and running. Of course, that was not homogeneous for the whole country. If you look into richer states, we, at no moment, like in Sao Paulo, I would say we ran into shortage of PPEs, but we have colleagues that work in much poorer states in which they had to buy their own PPEs and take into hospital to bring along with themselves if they wanted to be protected during their shifts. So in those areas, certainly many people were reluctant to go to work because they didn't feel safe, especially if you had to stay at the hospital whole day and then coming back home. There was a lot of concern whether you would be bringing infection back home to your beloved ones and your family. So that was a big deal for us.
Yeah, I'm particularly interested, your elective C-section rates are quite high. Did you find a reduction in your elective section rates? Because everything elective just went out of the window, didn't it?
I mean, we can talk about the experience we have in a small hospital that we managed. Our cesarean section rates did not go up altogether. Neither did the maternal request cesarean sections raise very much above what we were used to. In the private sector, however, elective cesarean sections are much more common. And and now we have rules in place in Brazil that don't allow you to perform any elective cesarean before 39. So it didn't really change our practice because this was already in place. Thankfully, we have left behind the ages when we were performing elective cesareans at 37, 38 weeks. And many babies go into Scabul because of respiratory distress. So that didn't change so much the practice.
Thank you. Thank you so much. That's very interesting perspective. My next question is to Tim. Tim, what strategies have you employed for obstetric emergencies during COVID-19?
Yeah, thank you, Rani. I think the key message to get across is that the management of the emergencies is the same. It's the infrastructure around it that has been different. So no one is managing eclampsia any differently than they were before. It's how do you manage it safely? How do you provide the Magsol for everything else that you normally would do? So I'm just going to talk about 6 general principles, and I will put in the chat box a video link that people can have a look at if they wish to see some of the principles of this. So principle number 1 of 6, ascertain the emergency before entering. In the old days, of course, anytime an emergency bell's linked, you run in. What you do know is if you're a COVID positive woman, or you're taking universal precautions, the more in and out you come, the more difficult, the more likely it is to increase the infection risk. Once you've ascertained the emergency, then you can actually work out what you're going to do. Then you can prioritize donning and doffing. So prioritize donning. And we would say, just as Dr. Shah said, just as Professor Chowdhury said, we would go for the most senior person, because actually you need the most senior person to start working first. And what we did show in some testing is it's quicker if two people arrive at the same time, it's quicker for the second person to dress the first person than it is both to get dressed at the same time. So we would say dress the most senior person, then the second person dress themselves coming afterwards. Now, keep a clean runner outside. So we would have someone outside the room who can go and get equipment and bring it into the room, or just pass it into the room. And we also developed, instead of PPH boxes or eclampsia boxes or all the sepsis boxes, whatever we have, we actually had plastic bags containing all the medications, all the stuff you would need, and used to take that. So if it was a PPH, you run in with the PPH grab bag. Therefore, everything in that bag can be thrown away at the end. Secondly, one of the big risks that's been identified is people forgetting to take off their protective equipment carefully and safely. And one of the things that was very heavily promoted by the anaesthetists and the national guidance is take your PPE off in the room, but take your mask off carefully away from your face after exiting the room. And then we did find, Rane, that rehearsal was very, very useful. And we also tried to learn as we went along. There were many things we didn't get right in the beginning, and we're much smoother about it now. And I will put the video in the website on the chat for people to have a look at if they wish.
And this video is a video of donning and doffing, isn't it?
Donning, doffing, and yeah, how do you get ready for emergencies? And it goes into some detail about the grab bags, everything else as well. But I guess everyone else has come to the same sort of emergency care, I would imagine.
Yeah, thank you, Tim. A really interesting few things that you did, but I was particularly interested to hear Adolfo say that the pandemic came to them later on, so they had learned from what else was happening. And I think that's quite important, that they were actually prepared for it, whereas the rest of us were totally unprepared.
Well, one of the problems I think we had right at the outset was the drip, drip, drip of very, very small numbers of patients being published from China, very small series being published from China, which were very difficult to interpret. I mean, let's face it, the UK did not do terribly well in COVID. I think we still have, unfortunately, the highest death rate, not in pregnant women, but the highest death rate in the population per 100,000 people. So we didn't do brilliantly, but it did allow us to kind of learn on the job. And I think one of the things that the RCG tried to do was produce national guidance to reduce the workload and burden of producing out guidelines at local level in every single unit in the country. And I know.
Yeah, Tim is getting intermittently cut off. Tim, you get intermittently cut off, but I think what you wanted to say is that we produced a lot of guidance on the RCOG website, which is available also to everybody. And we do know that a large number of people have accessed this guidance. I mean, it's really gone completely crazy, the RCOG website and the Instagram and so on and so forth. So that's quite important. But I think what else added to the problem was the confusing guidance we were getting from the government. And I think one of the persons who can really help us understand this better would be Dr. Kabango, who is a Chief Medical Officer for the Namibian Ministry of Health and Social Services. So could you expand on how governments and policymakers can contribute to maternity care during COVID-19? And were there any lessons you learned in your practice?
Much for the question.
The question was about how governments and policymakers contribute to
yes.
care.
Yes, I got the question. maybe what we have seen been done by different government and different policymakers, they have developed actually policies and guidelines to try to guide the practice. We have also seen an increase in health financing in terms of COVID-19, both for hospitals and operational levels and public health. We have also seen that government and policymakers have put provision for training of healthcare workers and the recruitment strategies and the retention of especially experienced practitioners during this period. The other thing that policies makers have made is to try to assist on the flow designs of patient, and also in obstetric practices, providing more guidelines and SOPs, operational document to help the practitioners to be most of the time on the safe side. We have also seen an increase in essential medical equipment, especially for obstetric care. A lot of equipment have been purchased, pharmaceuticals and consumables. On policies and guidelines, basically, there have been a lot of multi-sectoral consultations within the different international agencies, WHO, UN, NGOs, and the scientific communities to come up with broader policies to cover for COVID-19. I think these have been ongoing activities every year, and then we see new guidelines coming on board to try to guide as we are learning in the field from the practice. We have seen also one of the most important policies that have been put in place now to do the screening and to detect and to isolate. That's a very, very important to actually manage cases, to make sure that the health system does not collapse, to make sure that cases are detected early and they are isolated, and the contacts are actually followed and they are tested. Another policy that was very, very very good was to prioritize the maternal child health during the COVID-19 as essential service, to make sure that we don't actually lose the gains that we have actually achieved. You remember from the Millennium Development Goals and now from the SDGs, and the pandemic is there, but we want to make sure that we don't lose the gains that we have achieved. And we have seen in different settings where, for instance, rotation of midwives to go and cover medical ward was actually not acceptable, just to try to keep the essential services in maternity ward. We have seen the development of standard operating procedures for maternity ward in terms of IPC, in terms of case management, in terms of vaginal delivery or assistant vaginal deliveries and cesarean section. I think we have seen the development of the checklist, surgical safety checklist for COVID, which incorporated the donning and doffing and all the infection protocols around the time of the operation. So these are some of the policies that have been developed so far. We have seen in terms of health financing, I think governments have consulted the managers at different levels. I think this time we have seen that operational managers have been involved in the financing and the allocation of budget for COVID. We have seen stimulus packages being distributed in some settings to women who have no employment, in some settings to people that have lost jobs and have lost incomes. And that have actually led to some good outcomes. We have seen improved communication network in terms of remote screening. For instance, we have seen in some settings where people are doing ANC remote screening. We have seen the establishment of call centers and patients are freely engaging with healthcare workers remotely and discussing if really it is necessary for the patient to come for face-to-face examination. We have also seen an improvement in terms of referral systems. It's a provision of referral mode like ambulances and service kits and women empowerment in some settings. During COVID-19, there have been a reduction in gender-based violence. That has been actually something affecting maternal health. In trainings and recruitment and retention strategies, I think government and policymakers have made sure that all the healthcare workers, the frontline workers, are trained in infection control practices. They are trained in case management for COVID-19. They are trained in critical care. And now we are training people on safe cesarean section and the surge capacity and management, especially when you're anticipating to have so many cases to come. You need to be ready and you need to mobilize your resources to make sure that you are able to function. We have seen also retention of experienced obstetricians and midwives, and some of them that were already retired have been recalled to come and boost the system. And also we have empowered trainees, for non-complex tasks. Yeah, that has been something very good. Student, nurses, student, medical student, and so on, they have been empowered to take some tasks during the COVID. Another milestones which we have seen, I know time is not with us.
Yeah. Do you have anything governmental, because you're kind of going out of that area? Anything about government policies, focusing on government policies?
Yes, government policies, as I mentioned, I think the policies on how to detect, how to manage COVID-19 patient. We have also seen a policy on how to redesign the patient flow in maternity ward, where some of the hospitals are constructed different maternity wards. Some of these hospitals have actually redesigned the flow within the hospital itself to have different entry and exit point. We have seen also the supply of PPEs and train midwives and obstetricians to make sure that availability of PPEs and people are trained on dawn and doffing during all the obstetric procedures. Okay. So these are some of the policies we have seen during the COVID-19.
Thank you. We have people from different countries. Is there anything different that anybody would like to? And show me a physical hand, because this electronic hand is rather small and I'm getting a bit distracted by looking at this. I'm going to, all the panelists, if you have anything to add, if you could just raise your physical hand. Anything about government policy. I think it would be fair to say that some things did improve because of COVID. That is the silver lining to this rather gray cloud that COVID caused, but there were a lot of positives. We too saw in the UK that there was money pumped in. We don't know what's going to be the effect afterwards, but there was a lot of money pumped in. And I would say from point of view of policies in the UK, there was a lot of confusion from our government side, which continues. If you watch BBC, you will see that. But is there anything, Adolfo, would you like to add anything about what happened in Brazil?
Yes. The Brazilian constitution, it establishes a percentage of the budget that's spent in each area, educational, health, and so on. And the discussion currently is that the budget for this year was, although many elective services were suspended, cancelled, this budget was transferred for this to supply for this pandemic, the equipment and all the necessary changes to face this crisis. And the discussion now is regarding the next year, because we will have to catch up with the work that has been postponed. And there is the natural new cases that will continue to surge. And we are tied to this budget constraint now of what was planned for the next year. I think the health crisis will still last for a couple of years. And there's not talking about obstetrics, because most of obstetrics we know cannot wait. So service kept on being provided. But many other specialties will now face the real crisis coming ahead in the near future, we believe.
Yeah. Milan, would you like to tell us what happened in India? Was the government helpful? Did they have policies, or was it a mess?
No. Actually, to start with, there was a lot of burden on the government sector when the pandemic started. and they compulsed actually all the private sector clinicians to work, and there was little rifts to start with. But eventually, many organizations came up for the mutual understanding, and they realized that certain private practitioners also had comorbidities, and they were unable to work, and some of them were not willing to work. But slowly this actually situation changed, and now in India, the both sectors work very effectively to address this problem of COVID pandemic. Regarding the government policies, again, they had little ups and downs as far as the supplies of drug as well as the PPE are concerned, especially antivirals. But slowly government started allocating more budget for this particular problem as well. And now in government sector, all antivirals are very much available. The patients are treated very effectively. Recently, we are facing one problem of oxygen supply because of usage of this high flow nasal oxygen. In many of the cases, many of the cities in India, they got the scarcity of the oxygen. But again, the steps are taken by both the government as well as the private sector to overcome this problem as well, and the oxygen is now getting supplied to all hospitals.
It's funny, isn't it, how it takes a pandemic to cause improvements.
Yes.
Meena, I can see your
Yeah.
hand is partially up.
Yeah. So I would just like to add to what Dr. Millen had said, that initially, because there was a really shortage of supplies and also the hospitals, but I think the government went out of the way to upgrade all the district hospitals, even at a very basic, now they have these ventilators because they were not there. So now, like the COVID dedicated facilities, they're not overburdened. They don't have a waiting list. So people can manage, the patients are being managed at their own places. So that they've gone, I think, really accelerated in upgrading their hospital setup.
Sure.
And initially they also, the lockdown that they did, which was initially total and then partially removed step by step, I think that was the time that we could prepare our institutions, our facilities with all the things that we needed to take care of such patients.
Yeah, so that initial lockdown was quite helpful. Shaheen, could you tell us what happened in Bangladesh? I see your hand up there.
Yes, I just wanted to add up here about our government policy. With the pandemic, government has taken some steps which are really appreciable. First of all, they selected some high group of experienced doctor to come with the protocol system to make. So that was one side. And the government has taken a very big step in spite of low and middle income country. They dedicated those COVID hospital, not only government, those are private hospitals they designated for COVID hospital. All the patients there are having every service free of cost. Government has taken the whole bearing effect on this. And also at the same time, which is very helpful for us, because we know in Bangladesh, a lot of families are joint families. So a frontliner, when they're going at the front, they have worries about home, having elderly parents, children. So government has, from the very beginning, from March, they accommodated different hotels for the frontliner. They accommodate the transport, they accommodate the foods, and everything all over the Bangladesh is free. So that is very actually supporting for us. So this is I wanted to add here.
It's really wonderful to hear. Tim, have I covered most aspects about UK when I'm talking, or is there anything I've left out?
No, perfect.
Yeah, thank you so much. So the next question is to Dr. Meena. What are the recommended strategies to ensure safety of the working environment during cesarean delivery for COVID-19 or suspected patients?
Yeah. Okay. So what basically we are practicing here is we have different OTs. Two, those are situated in the maternity area. They are for the usual routine cases. There's another one in the opposite area, which is in the which is dedicated, marked for the COVID positive patients. Having said that, we know that many of our patients, they're not tested for COVID. Even they have tested, their reports are waited. Sometimes the reports are negative, but they have symptoms. So even when we are taking them as routine cases, to ensure that we take all proper precautions, because any one of them could be positive and could be a source of infection to others who are there. So that is one thing. Then we've just heard Dr. Tim talking about the donning and doffing. So the area there, dedicated area for the donning, and chart there telling all the steps so that people remember to do it the right way. And while inside the OT, the checklist has to be there, and minimum people should be there inside the operation theater. And the first person to go there should be the anesthetist. That is what we are following, the nurses, then last the surgeon for herself, and neonatologist the last for the shortest period of time. Then about the anesthesia, we would definitely prefer the spinal or epidural, because we know the aerosols are more with the GA. And I think during these, except for one case, I've not seen them giving GA for any patient during this time. Then again, use of cauteries, we are doing away with it for the time being, for the fear of aerosols that they create. Then a negative pressure OT is preferable, though they're not always available. Not all our OTs, they have the laminar flow, but that is what is desirable for these patients. Then after, once the operation is finished, how we take off the doffing part, and how to, put our, what we have removed, our gloves, masks, what has to be disposed of, and what is being reused, where to put them safely, how to, that is a part of the training ongoing and practicing, putting on the mask, how to remove our gloves and masks, and so on. And then even the recovery is different for the positive patients and our negative usual routine patients. So that is the safety aspect, and also the cleaning part. What we are following here is the fogging morning, evening, and after every cesarean, the sweeping part with the 1% hypochlorite solution, all the surfaces. So that is what we are following, and that is the recommendation of the ICMR as well.
Okay.
So that is about, and
okay.
so
yeah, go on. Sorry, Meena, did you finish? No. You cut off. And
yeah, that is about it. Yeah, that is about it. And about the baby. Yes, now if the mother is positive, and most of the times our baby mother unit remains the same, teaching the mother how to, the hand hygiene, how to put on a mask all the times, because we are mostly catering to sort of negative patients who could possibly be positive as well. And even in positive cases who have turned out to be positive in the tests, because they're not serious patients. So we don't separate, and most of the times it's not practical to separate mother and the baby, because we don't even allow many people to come inside. The attendants are limited. So the practical part of it also is there. And so we're not actually avoiding breastfeeding, but telling them the safe way to do it.
So this is a very important aspect, because this caused so much confusion in the UK. Breastfeeding, the relationship between the mother and baby, what do you do with the baby, where do you put them, etc. So I'm really interested to hear what the rest of the panel have to say about this. I can see, I'm going to ask each one about this, because I think it's so important, because it caused such a ruckus everywhere. Adolfo?
Thank you. I had one question for the panelists. For those of you who are in teaching hospitals, what was the policy regarding training OBGYN residents during this pandemic? Whether they were allowed to practice normally? Were they allowed to participate in all procedures, OB procedures as the usual? Or did you have any change?
Yes. So I think it was different everywhere. Shall we start with Dr. Kabongo?
Yes, of course. What we have usually seen is that, especially private sector, obstetricians, gynecologists will prefer probably to have the required COVID test for their patient, especially those who are elective cases. Also, in an emergency situation, they usually do a COVID test before the procedure, and follow up with the result after the patient has delivered. Of course, making sure that the team that is involved are actually protected with appropriate PPEs. In terms of training, I think the training has been cascaded to all healthcare workers. We did not have any special training for specialties or different specialties. So when we do training for infection control and prevention, we do the training for everyone. And when we do training for case management, we do training for those that are involved in case management. When we do training for critical care, those are in critical care that are involved. But the basic training is ICP, infection control and prevention. And of course, for cesarean sections, those who are involved in theater, to make sure that appropriate PPEs are worn at that time. So there was not really a difference in terms of training. In terms of practice, we have seen also that it was also personal preferences. Some gynecologists probably they wouldn't prefer to work for a certain period of time, but we have also seen that those have been exposed to positive cases. They were put on quarantine for 7 to 14 days pending their result. If their result are positive, their isolation is extended. So this is what has been actually been happening. Yeah.
Thank you. Shall we just focus on the training question, because there are loads of questions coming in. Questions are being answered by our panelists in the chat box and the question box. So I will be answering the ones that Kitty sends to me, but there are loads of questions. So just let's focus on the training aspect. Prof. Shaheen, do you have anything to say?
Just to mention that, because those there is no what Adolfo was asking about the training learning process, but it's not there. What we are doing, mostly focusing on the IPC, those are coming at the front line now. We make sure that every time they are coming in the group of for their duty, we make sure we have 2 or 3 classes with them to give the moral support, as well as how to deal with the IPC and how they should be actually serve the patient. Because as you can understand, everywhere the big problem is communicating with the patient because of the fear. People are not going close to them. So we need to boost up them. That was our main sort of thought at this time. IPC, donning, doffing, and how to cope with this from stress.
You had to do quite a lot of training. Milind, anything to add? Yes?
Yeah, I think Adolfo wants to ask about the training in the other actually areas apart from obstetric for the gynec residents. Is it true, Adolfo? You want to ask that way?
Now, whether your OBGYN residents were allowed to practice, carry on with their training during the pandemic, and if they were allowed to be in hospital, whether you had any restrictions to what they could do or could not do.
Yeah, see, basically in India, what happened, many of these residents were working very effectively. Rather, more burden was on them because the professors and the higher cadre had certain comorbidities. So naturally, the residents were working very effectively. But the one question, as you said very correctly, is suppose those residents want to learn OBGYN and suppose you lose 6 months only in obstetric cases. What about other surgeries? What about the hysterectomies? What about the other elective procedures? So the burden was so much in medical colleges because of more number of cases. It took some time. For a certain period of time, no elective surgeries were planned to overcome this particular problem. But eventually, when the things got delegated to various levels, now all medical colleges, they have started with the elective procedures as well. And slowly they are imparting this training to resident doctors.
Thank
Thank
you.
you. So you've given us the India perspective. Tim, do you have anything to, I know you've been putting things in the chat box, but I think there were specific things that happened in the UK. Would you like to share those?
Yeah, I'm not a particular expert on training in the UK. Sue Ward and Joe Mountfield, the other vice presidents, are super experts, and I'm sure would be loved to tell everyone. But the big problem we had, just like Dr. Shah, was the trainees made a huge contribution to the obstetric service, but there is no elective gynecology, or very, very little elective gynecology, which makes training for O and G very difficult. And that has still not been resolved in the UK. There has, I think, just this week, trainees are now allowed to work in private hospitals with NHS consultants. So that may help the situation in the UK. But yeah, we're in a very difficult situation where there's very little elective gynecology work, which makes training very difficult in that particular area. So Adolfo, I can see you nodding. I'm not sure it's soluble until we can get back into elective work.
Sure.
I think it would be fair to share that training has been affected. They were all mobilized to the front line, and they have done a fantastic job, I would say. I have a question for any of the panelists now. How did you organize your antenatal care? And after you perhaps had virtual clinics or whatever, have you continued to do them? Or have you gone to face-to-face? Adolfo, do you want to share?
Okay. Yes, we do provide antenatal care. We carried on with antenatal care. I mean, in all units, all the specialties, medical doctors were dismissed during the pandemic, except for those that were providing care for oncology and obstetrics and psychiatry mainly. For obstetrics, what we managed to implement was on the previous day, patients would receive a phone call to check for clinical symptoms to see whether they were suspected to be COVID. And if so, their appointment would be canceled and they would be instructed to go to the emergency room to be checked instead, where we would be ready for a different flow. In our antenatal clinic, we did not have the structure to have a different flow. For those women that unfortunately sometimes could not be reached by phone, and they presented for the appointment and they were symptomatic, we would try to advance them to see them as soon as they arrived, to dismiss them as soon as we could. We were not very successful in the public health system to implement consultations by telemedicine. That unfortunately is not our reality for most of the patients because of social, economical conditions, limitations. So yes, we did carry on with the service, but within these terms.
Thank you. Who was practicing remote medicine for your antenatal patients during the pandemic? Put your hand up and I'll ask you. Were you practicing, Milan, remote?
Yeah. See, what happened, basically, I'm having, as I told you, one at my place, Solapur, and one in Mumbai. So all the patients who were actually in other place, they used to avail the teleconsultation. Fortunately, the Medical Council of India allowed during this pandemic teleconsultation, but of course with the limits. We had a very good apps came up which had a very systematic addressing towards this teleconsultation, where there should not be any sort of pitfalls as far as the service is concerned. And whenever there is emergency, as told by Adolfo, the emergency room option was always there. But quite few of the antenatal visits were curtailed down during this pandemic period because of this teleconsultation.
So are you going to continue afterwards, or are you going to go back to face-to-face?
Yeah, it all depends, but basically many of patients were very comfortable with teleconsultation. We are going to continue it as far as our policies allow it to do that way, because that will definitely reduce the burden.
Sure. Anyone has anything else to contribute to that? Do we know whether it's better than face-to-face? Do we have any idea? Yes, Shaheen?
Yes.
If it, just answer if it's something different, because there are loads of questions. So if you did, yeah, if you did.
It's not different as such. What I wanted to mention, that we have been giving service face-to-face as well as tele, both going on together. And initially it was more tele, but as I said, we are actually saturated with the problem. So we are facing face-to-face, but we have cut down the antenatal visits, not as before, but face-to-face is going on now from the last 2 months. And hopefully we will continue that.
Yeah. But it obviously has reduced the number of patients that can be seen in each clinic, because
yes,
you make sure that there's social distancing, you clean up afterwards well, etc. And how did you manage scans in this situation? How were scans managed if you were with telemedicine? Is there anybody has any fantastic ideas? What happened with scans still?
So I was just about to start typing, but so in the UK, we reduced the number of scans in the really difficult pandemic time. And this is the problem of remote and antenatal care. There's more to antenatal care than just speaking to people. There's measuring the blood pressure. There's finding out which way around the baby is, or whatever, how big the baby is, all those other things. One of the things we're also very worried about in the UK is some of the most vulnerable women in the UK, women with domestic violence at home, women with very difficult circumstances, are the least able to take a call at home. And so we're actually doing some research to try and work out how we should do remote care successfully. One thing that has been very, very successful, I've just put it in the conversation box, is using apps for women to manage themselves. And that has reduced antenatal visits whilst maintaining very good outcomes, and has been extremely popular, particularly for outpatient blood pressure monitoring. Has been a very successful story in the UK.
Yeah, thank you. Dr. Samant, you gave us a good insight into cesarean sections and how we should manage it. Do you have any questions about the suitable dress of the surgeon during CS?
Yeah, the PPE kit that is what we are following.
Yes, and what exactly?
Even for, so what we are doing is we have, of course, first the cap, the goggles, or the face shield, the mask, the N95 is what we're using. And that water resist, that one-piece suit that is being put, and the shoe cover. So that is what we're using, and double gloves.
Double gloves, and which mask are you wearing?
N95.
For all of them, whether they are positive or negative?
Yes, we're using N95. In the OT for cesarean, we're using N95.
Is it different elsewhere? Or is it?
We are using same.
For all whether it's positive or negative?
Yes.
We're currently also using N95 masks irrespective of COVID status of patients, but this was a recent change. Before that, we were still using simple masks. when we thought the patient was negative, but currently we're using universally.
Universally.
N95 masks and protective glasses at all times.
Yeah. And Tim, that is what you're doing in your unit as well?
Yes. I couldn't type and speak at the same time because I'm a man.
I know you've been doing some ferocious typing. Thank you so much. I want to ask you, Leonard Kabongo, I can't see you. You've gone away. So did you alter the checklist that you used?
Yeah, so the surgical safety checklist has been modified to incorporate the COVID-19, which is actually some consultation of Lifebox, which came up with that checklist. Although it's not yet widely, distributed, but for instance, in our hospital, we are trying to start using it now. But of course, before that, a lot of training already taken place in terms of donning, doffing, and infection control practices during surgery. Make sure that the team wearing N95, the eye shield, and apron before you can dress as a surgeon, double gloves as well. So we will see the coming weeks with the very high local transmission. Probably most of cases might actually be asymptomatic cases and so on. We want to emphasize on that checklist. It's still quite new so far.
Sure. So the checklist is available on Lifebox website. Is that the same that you have used, Milind?
Yes. In fact, we had a very wonderful TOT on this COVID checklist, and we started utilizing it. And we have also modified slightly for our current setup as well, which was a little more adaptable to the other health providers as well. But it was a really wonderfully prepared checklist, I would say, by Lifebox and Japago.
Thank you. Are the other panelists using the same one or an alteration of their checklists? Adolfo?
We haven't really changed our surgical checklist. What was changed was the admission checklist during triage in emergency department to include questions regarding this respiratory symptoms. Initially, we were restricted to questions like if you had traveled or contact someone with COVID, and then gradually with time, the checklist questions had to be changed to be more universal. But essentially the checklist that was changed was during the triage at admission.
Thank you. Meena, anything to add to that?
No, I think our checklist was also at the emergency point.
Yeah.
With all the history of travel and symptoms. And of course, testing has been added now. Yeah.
Sure, sure. Thank you very much. We're slowly coming to the end of this, and I have so many more questions. We could go on for 2 more hours, but I can't do this. You've already spent an hour and a half here. But I'd like to end with one question. I'm really into new innovations. And the one last question that I'd like to ask you is that if there's one innovation that you found useful during the crisis, did you find anything that you could use on your labor ward, specifically on your labor ward during the pandemic? Something new, innovative. Shall I start with, I'll call out the names as I can see you on the screen over here. Leonard, Dr. Kabango?
Yeah, something useful in labor ward is mostly was to make sure that the healthcare workers are protected. So every time you do admission for any pregnant woman, you should have actually appropriate PPE. And that has actually worked. Even though you continue doing the scans, we are doing the scans, we are still doing the scans face-to-face, but we make sure that the provider is actually wearing PPE, at least a face mask, eye gear, an apron, and gloves when we are attending to patient. So that has been actually worked. In my settings, we have had more or less zero transmission on healthcare workers.
Professor Shine has changed her name just to confuse me, but I still here. So Shaheen, you've changed your name to Saira right now. Saria. So Shaheen, any innovation in Bangladesh? You're muted.
I was just rejoined because I was out of electricity, so I actually couldn't follow the last bits here.
Yeah.
So,
yeah. So the question was there any innovation that you found useful during COVID? Anything new practice that the people who are watching us can take back, learn?
I think one of the important thing is the COVID has actually teach us how important it is to have a relationship with not only with our patient and also with our general people, because the anxiety we faced, and all of us, not just junior people, top to bottom, the anxiety we faced, the fear we had, which actually took us from well ahead from our daily, the commitment as a doctor. So I think one thing we should learn that COVID has teach us that we need to actually improve ourselves in terms of communicating with patients, especially those patients who really needed us during this time. So that is a big change we have to learn. And also I have seen that the new generations in our country especially, they're very sort of energetic and enthusiastic, and some of them voluntarily, some of our intern is actually involved in serving these patients, so which is a good motivation from the younger generation, which is very appreciable. Thank you.
Thank you. Adolfo?
Right. One innovation that will certainly keep on after the pandemic is a portable negative pressure equipment that was developed in the hospital. This came out as a partnership between our innovation department and a small startup company. And it's really a very compact structure that now we can have in all our labor and delivery suits. And this is particularly useful because we do still use nitrous oxide for analgesia during labor. We cannot give epidural to all women, so we're still using gases during delivery. And there is a long-term concern about the exposure in health workers, prolonged exposure, especially midwives. So that's something that will definitely remain in all our rooms, that will allow negative pressure in these rooms.
Thank you. Tim is going to have to go, but Tim, one innovation, you can say it in one word or two words.
Apps.
Apps. So you thought apps was very innovative?
I think it's at least partly the future. How do we help women look after themselves? And how do we keep people out of hospital who don't need to be in hospital? I think most people have a smartphone in many, many areas of the world. And I think this is the future. And I think we need to make sure it works, and we need to harness this kind of technology to personalize care in 21st century obstetrics.
Thank you. Meena?
I would say hand hygiene, that's come to stay anywhere, everywhere. I think it's become part of a habit.
Thank you. And Milind?
Yeah, the webinars. It helped a lot for all health providers to get more and more involved with the webinars, both way, the faculty as well as the trainees.
I would say that there's a pandemic of webinars going on right now.
Yes.
Yeah, but to me, that I look at it as positive, because it really is a silver lining. It has increased our outreach, and I think it's quite wonderful. Who would be sitting here on a Saturday talking about C-sections from everywhere in the world? So I think that's absolutely fantastic. Now there are loads of questions there, and I know that you all have been answering because I see them popping up. I hope we have managed to ask you every single question that you have asked us. Probably missed a few. If so, please send the questions on to Kitty. We will get them answered for you. And with that, I'd like to bring this webinar to a close. I'd like to thank our wonderful panel. We have learned so much. Our hosts, Lifebox, and who have hosted our COG. And thank you all for joining us. Normally, I would love to say safe journey, but now I'm going to say keep safe. Health professionals, I've never been so proud of my profession. We have gone out, we have shown leadership, and I think we have all done a great job, and all of you need to be proud of what we do. Now, video recordings of this will be available at lifebox.org next week, and Kitty will email all registrants of the webinar with the link to the recording as well, so you can have a look. There are also lots of key resources there. Thank you so much, and keep safe wherever you are.
Yeah, and on behalf
Thank you.
of
Okay, bye-bye.
yeah, just
Bye.
one second. On behalf of all of us, we must say big thanks to you as well, Rani, because I know to moderate a panel with so many experts is sometimes difficult, especially to stop them.
No, you did well. You did well. Thank you so much.
Thank you.
Thank
Bye.
you.
Thank you, Rani.
Thank you. Bye.